All right, good evening. Welcome all of our attendees. Thank you for joining us today for our January webinar for the Midwestern Vascular Surgical Society. Thanks on behalf of myself and my co-moderator, Dr. Duncan. Today's topics we'll discuss are revolving around complex open endovascular and hybrid aortic repair. And we have a wonderful panel of speakers this evening. For our attendees, please use the Q&A feature on the Zoom to type in questions. We'll plan to go through all of our talks and then do a Q&A at the end. But if you do have a specific question for a panelist, perhaps call that person out in your question. I'd also like to thank Terumo Aortic for sponsoring our event this evening. And with those introductions, I'd like to introduce Dr. Cavusi, Senior Staff Surgeon at Henry Ford Hospital in Detroit, Michigan, to talk about open versus endovascular aneurysm repair. Thank you.
Thank you very much. I will try to share my screen now. Sorry about that. I think I'm almost ready here. Can you guys see my screen?
Yes.
Okay, thank you very much. Thank you so much for inviting me to discuss this potentially controversial topic. I have nothing to disclose. The history of open aortic aneurysm repair begins 72 years ago when Charles Dobas in France performed the first successful resection of an abdominal aortic aneurysm and replaced it with a cadaveric homograft. This marked the modern era of surgical repair of a common entity. Here is a diagram of his operation, which was published in 1952. Since then, there has been major advances in open repair of aortic aneurysm, including development of synthetic vascular grafts, endoaneurysmography, blood component therapy and autotransfusion, improved anesthesia and postoperative care, and advanced cross-sectional imaging. This is an original picture from the Creech paper in 1966, describing his endoaneurysmography or intrasaccular repair. In regards to evolution of endovascular AAA repair, Juan Parodi in 1991 published his experience with retrograde deployment through the femoral arteries of a stent-anchored Dacron prosthetic graft in 5 patients. This marked the beginning of minimally invasive AAA repair as an alternative to open surgical repair. Regulatory approval for the first abdominal aortic stent graft occurred in 2001 in the US, and market rapidly expanded, and there are currently 7 commercially available endografts. Endovascular repair has gained wide acceptance and availability since then, in large part due to advances in stent graft design. Anatomical suitability is the key factor for successful endovascular repair. This includes aortic neck length, diameter, angulation, aneurysm morphology, and iliac artery anatomy, presence of calcification or thrombus. And additionally, it's important to stay within the FDA-approved instructions for use for any particular device. Like any other technique, EVAR has various failure modes. Endoleak is the Achilles heel of EVAR. It occurs in up to 25% of patients. Other problems include stent migration, stent graft fatigue with strut fracture, as well as problems that plague the open repair, including graft limb occlusion, infection, and enteric erosion. EVAR has now been widely accepted in the US, with over 80% of aneurysms repaired in an endovascular fashion. The shift in treatment pattern has been associated with a decline in open surgery rate. As seen in this graph, using a national inpatient sample from 2004 to 2015, Dancy and Associates demonstrated that in 2005, EVAR surpassed the number of open repairs for intact AAA repair, and the proportion of EVAR reached 85% by 2015. There has been many studies comparing the open and endovascular repair of AAA as it pertains to outcomes. There are 3 principal randomized controlled trials, namely EVAR1, DREAM, and OVER trial that we are familiar with. I have also included the ACE trial here. all of which have shown marked benefit of EVAR with respect to 30-day mortality, as you can see here, comparing the numbers. In a meta-analysis of individual patient data from EVAR-1, DREAM, OVER, and ACE trials, comparing outcomes of EVAR versus open repair over 5 years, in an unadjusted hazard ratio, you can see that between 0 and 6 months, mortality was lower for the EVAR group, and the early advantage, survival advantage of EVAR in the first 6 months was largely attributed to the lower 30-day operative mortality for EVAR versus open repair. However, after this, the early advantage for the EVAR group was lost, and the hazard ratios moved non-significantly in the direction of open repair, as you can see here. That being said, I don't think we really need randomized control trials to prove the tangible and obvious benefits of EVAR, including minimally invasive nature of it, with less major complications, shorter operative times, reduced blood loss, rapid recovery with shorter ICU and hospital stays, as well as a high degree of patient acceptance. It is particularly attractive in high risk and frail patients. On the left side of the screen is a patient of mine, status post standard EVAR, 2 hours after surgery in the PACU, and then the patient on the right side is one of our patients after an open aortic aneurysm repair, granted not infrarenal. In terms of perioperative mortality of EVAR versus open repair, as mentioned before, based on the randomized control trials, there is a reduced 30-day mortality with endovascular repair. In a retrospective propensity score matched cohort study, which was done by Schermerhorn and Associates, they identified all traditional Medicare beneficiaries who underwent elective endovascular repair or open repair of abdominal aortic aneurysm between 2001 and 2008. In this review of 80,000 Medicare patients, they confirmed that the results of the randomized control trials are in fact representative of current outcomes, with overall perioperative mortality of 5.2% in the open group and 1.6% in the EVAR group. However, concerns remain over the longer term outcomes and survival benefits of EVAR. In the same study, looking at freedom from complication in 8 years, aneurysm rupture occurred in 5.4% of patients in the endovascular repair cohort versus 1.4% of patients in the open repair cohort. Aneurysm-related interventions were more common among patients who had undergone EVAR as compared to open repair. That's 18.8 versus 3.7%. And the overall combined rate of aneurysm-related interventions and interventions for complications related to laparotomy was 25% in the endovascular repair cohort versus 20% in the open repair cohort. And both cohorts had similar long-term all-cause mortality. Also, as you can see in the curves for the rate of rupture or re-intervention, the risk of late events was greater in the endovascular repair group as compared to the open repair group. In another cohort study of more than 32,000 abdominal aortic aneurysm repairs in a Medicare matched database, open repair was associated with higher odds of 30-day mortality and perioperative complications. However, it was associated with a lower rate of 6-year mortality, rupture, and reintervention. And I think this is probably the best real-world data yet. And there's also more contemporary data. As we all know, there are major criticism regarding EVAR-1 trial, including but not limited to the use of old technology, inexperienced surgeons, and rudimentary secondary treatments. However, contemporary data from population-based studies also show lower long-term survival with EVAR cohort, similar to longitudinal follow-up results of the previous randomized control trials. In a recent retrospective cohort study of veterans with AAA repairs from 2007 to 2020 at VA facilities, 15,480 patients were studied, and EVAR was associated with better survival up until 2.4 years post-procedure. The mean long-term survival, however, was superior in the open aortic aneurysm repair. There are more problems, of course, if EVAR is done outside of the IFU. The current US practice demonstrates liberal use of EVAR with only 50% within the device-specific IFU. A large multi-center Canadian study showed 44% of patients underwent EVAR outside of device-specific IFU. Several studies have suggested that EVAR performed outside of device-specific IFUs may contribute to endoleak and is predictive of sag enlargement and late rupture. There's also another large Canadian review that showed 79% rate of adherence to IFU in patients undergoing EVAR. However, In the patients requiring conversion from EVAR to open repair, there was only a 44% rate of IFU adherence. In a multicenter retrospective study, which was done by Charbonneau and Associates, the study population included 202 EVAR patients and 224 open repair patients with at least one anatomic IFU violation for EVAR. The all-cause mortality was 38% in the EVAR group and 24% in the open surgical group, with a median follow-up of 5 years. Also, aneurysm-related mortality was 4% in the EVAR group and 2% in the open surgical group. The authors concluded that patients with IFU violations have higher overall long-term survival with open surgery as compared to EVAR, and therefore caution should be applied in considering statin EVAR for patients with anatomy outside of IFU. There are also other reasons why EVAR fails. In a retrospective review of VQI database, looking at more than 21,000 aneurysm repairs, 15% of which were large aneurysms as defined by diameter of more than 65 millimeter, the 5-year adjusted reintervention, rupture, mortality, and loss of to follow-up rates for patients who had undergone large AAA EVAR were higher than those for patients who had undergone small AAA EVAR and large AAA open repair. Authors argued that for patients with large AAA who are medically fit, open repair should be strongly considered. Furthermore, I think their findings also highlighted the necessity of rigorous long-term follow-up for EVAR patients. Both techniques have their advantages and disadvantages. EVAR is minimally invasive, it has high patient acceptance, but applicability of it is sometimes limited. Cost is another issue that is very controversial, and there's no time to go into that at this time. And then in terms of long-term, there are concerns for durability, as mentioned before, and there is need for lifelong regular surveillance. And in some studies, there's increased renal dysfunction with EVAR. For open group, there is an increased perioperative morbidity mortality, but there's wide applicability. It has good long-term durability, but also plagued with laparotomy complications such as hernia and small bowel obstruction. Based on 2018 SVS guidelines, in terms of indications for open repair, patients who do not meet anatomic requirements for EVAR or outside of the IFU should be considered for open repair. Patients with mycotic aneurysms, graft explantation, or connective tissue disorder. Based on the 2019 ESVS guidelines, in most patients with suitable anatomy and reasonable life expectancy, EVAR should be the preferred treatment modality. And in patients with long life expectancy, open abdominal aortic aneurysm repair should be considered as the preferred treatment. For patient factors favoring EVAR versus open repair, again, EVAR is more suitable for older patients, especially octogenarians, for frail patients with multiple comorbidities, hostile abdomen, rupture, and also there is a component of strong patient preference. Open repair should really be considered in young and physiologically fit patients, people with anatomy unfavorable for EVAR, large aneurysm more than 6.5 centimeters, renovascular variants such as ectopic kidney, connective tissue etiology, dissection etiology, and poor compliance. In conclusion, EVAR has been a major advance in treatment of AAA, allowing us to extend benefits of repair to an increasingly elderly and compromised population. Vascular surgeons have a responsibility to use EVAR appropriately to stay within the IFU and to carefully follow patients forever. Open repair remains a safe, durable, and in some cases, a preferred options for patients, and will always needs to be done in basically centers that have possibly higher volumes, because as we all know, the open repair rates have substantially decreased in the recent years. And I think that we all have a responsibility to train vascular specialists that are competent in both EVAR and open repair. Thank you very much. And thank you to Dr. Shepherd for his mentorship and his help with this.
Thank you, Dr. Kavousi. A reminder for the participants, if you have questions, you can put them in the Q&A, and we're going to discuss at the end after all 4 talks. So the next speaker is Dr. Wesley Oman from Washington University, who is going to discuss what to do when standard EVAR fails.
All right, thank you for the opportunity to speak. I'm going to take this a slightly different way because Dr. Mawad is going to follow me and talk about open repair. So there's kind of really 3 ways to fix failing EVARs. One is open explant, which he's going to talk about. One is endovascular revision. And then the third is an honest conversation with the patient if they're too sick. Here are my disclosures. And I do want to be clear, I will be talking about off-label use of commercially available devices in terms of endo revision. The description of techniques and a lot of the outcomes really has limited kind of a good large literature experience with this, with any number of patients to be powered. And a lot of that has to do with the wide variety of indications for why the endovascular device failed. And these are all things that we intuitively know and see in practice. But largely, most of the studies have centered around this idea of a type 1A endo leak failing in those that are deemed unfit for open surgery. When you're approaching patients with a failed EVAR with a type 1A endo leak, there's several device issues that are specific to the device that was implanted or must be taken into consideration. The distance between the renal arteries and the flow divider, the stiffness and tortuosity of both the endograft as well as the native iliac system, suprarenal fixation relative to the renovisceral orifices can make cannulation challenging, and making sure you're in the larger of the two or sometimes three flow areas into those target vessels. And then what I like to term metal on metal on metal, and I'll show that in a couple of slides where you have markers from different devices overlapping all within the fluoroscopic view, and trying to keep those in line is very challenging and can often kind of lead you astray. And I think this comes intuitive to everyone, knowing that not all flow dividers are the same. Certain devices have a longer main body prior to the flow divider. This is an AFX and carries its own unique challenges with the orientation of the endoskeleton compared to the other devices in terms of cannulating and endovascularly revising. Similarly, some of the other more commonly used devices nowadays have very short main bodies prior to the flow divider. Not all flow dividers are the same, and that really kind of creates a much more challenging endovascular revision for these patients in terms of how do you manage the distal seal. 3 centimeters is kind of the minimum that most people aim for. That changes if you have a lot of tortuosity at the aortic neck. And so if you have a tortuous neck leading to the 1A and a short main body device, that poses its own challenges, and I'll get into one of the better described techniques in a second. So when you look at this, you can see, you know, the E2S on the left, the Anurex in the middle are both short main bodies, and that intuitively changes the seal relative to the length of the AFX or a Zenith device or one of the longer body Treos in terms of needing to approach seal. And so that comes into my first case, which is an 84-year-old male with a symptomatic 7-centimeter thoraco between a prior TX2 and an old Anurex, and you'll recognize the picture in a second. Obviously, a poor candidate due to age, but also generalized protoplasm with CKD stage 3 heading to stage 4, recent percutaneous intervention 18 months prior, and then 4 liters nasal cannula at rest. And he comes in tender despite appropriate blood pressure management en route. And this is what you end up seeing in Terra Recon, and this is not an uncommon situation where you have really kind of only the visceral segment that has degenerated with a short main body, really kind of limiting some of the options. And so one of the better described techniques is what we term an inverted lem. And for those of you who don't know or haven't seen it before, this is a very nice technique for managing these short main bodies, where you kind of take the lem, the contralateral lem, directly off of the device, essentially raising the flow divider of the new device that you're putting on. You leave the distal J distal, so you still have the marker for the orientation. But the power of this technique can be used for both the primary fenestrations on this device, as well as a distal extension if you're using a standard TVAR for your modification. And so here's some intraoperative pictures to show you. I use electrocautery to take it off, and then you just slowly advance it and re-sew it in place. You have to take great care at the crotch to avoid a source of an endoleak at that area, which can be revised with other devices in the future, but that's very, very technically challenging. So that's kind of the most commonly described technique for dealing with those short main body devices with a failing 1A endoleak. Here's what I talked about when I term kind of metal on metal. You really get a lot of difficult orientation and understanding, and these can be long cases, and the mental fatigue really sets in. So you have to be diligent with not only your endographs markers, but also the original ones that you put in. And then we talked about suprarenal fixation earlier. There is this concept of shuttering that was described early in the fenestrated technique, largely out of the UT Southwestern group, but that is still rarely seen with suprarenal fixation for some devices primarily. And then the way this is handled with fenestrations is the balloon test, making sure that the balloon expands without any significant waste. If you see a waste at a low pressure for your trial balloon, what I will end up doing is going to a really steep end on obliquity and trying to get the wire out what looks to be the largest flow channel throughout that aspect of it. It also poses difficult challenge in terms of getting the device there from iliac access. These are obviously don't have a failing endograft in them, but you could imagine tracking a much larger device than the original device often leads to its own host of challenges. And this has been seen from the very beginning of endovascular aortic repair in terms of the Anurex experience, as well as more modern experience, even at some of the newer, lower profile devices. A 2% intraoperative rate is great improvement, but is still something that can happen in these cases, tracking bigger or stiffer devices. And even once you get the device there, there's still a challenge in terms of managing the iliac access. There's a tremendous amount of play that comes in terms of the loss of trackability, the loss of one-to-one movement with the wires, the catheters, and the devices that really kind of necessitate having a full toolbox of endovascular techniques and steerable catheters and sheaths, and sometimes alternative access. You also have to be careful getting these devices in. Sometimes there is a risk of a component separation of the contralateral limb leading to a type 3 endoleak. So an angiogram on the way out, specifically looking at that is fairly essential. And then at the end, once you get the device in and you get everything tracked in, these cases with all of that tortuosity in the iliacs tend to cause the devices to really want to ride on one side of the wall versus the other. And so here you can see the deployment mechanism for the device, the proximal cap, getting stuck on that inner curve of the aorta, even after everything's been cannulated and we're kind of thinking we're on the downhill stream or downhill side rather for these operations. There's still various pitfalls all throughout the way. So in terms of specific endovascular outcomes for specific endovascular revision of failed EVARs, a lot of these are coming out of the ARC group or other groups who hold physician-sponsored investigational device exemptions. And so this is the South Florida experience, specifically looking at their physician-modified endografting revision of failed endografts. So they coned it down to really just the 9 patients that they looked at. Roughly half were pararenal, the other half were thoracoabdominal, only 1 chronic dissection and 1 symptomatic. The mean number of fenestrations for these devices is 3.7. You can see that they're often far delayed from the time of the original implant, going out to 65 months in this experience. And these are often aneurysms that have continued to dilate, and they're retreating up about 7 centimeter aneurysms. Low numbers, but they did have a single spinal cord injury in the cohort, which did lead to an 11% major adverse event rate. And they did see continued endoleaks, whether it's a type 2 or a type 3A, at the completion of their 30-day follow-up, The largest experience actually comes from the Europeans. This is in the Annals of Surgery from January, looking at what they term the EU FB Endo Fail Registry of 526 patients for a variety of both open and EVAR revisions. The median time to EVAR, reflecting kind of the changing technology, was much shorter than the interval to open aortic repair. However, they found no difference in technical success or 30-day mortality. They did see a higher 5-year patency, a target vessel patency rather, for those undergoing percutaneous or previous EVAR revision. But what they really saw was a fairly dramatic drop off or loss of benefit if there was a previous EVAR undergoing failed endovascular or failed EVAR undergoing endovascular revision. You can see that in the bottom right corner, where there's a tremendous separation of the Kaplan-Meier curves out at that 5-year mark, suggesting that there is still some portion of the aneurysm either untreated or some limitations in our current technology and understanding of how to treat these patients. And so as we all know in the talk, proximal neck is where these device fails. It's really critical to understand both the implanting device as well as that should be the previous device in terms of the markers and the orientation. The critical thing and the Achilles heel of these procedures for the 90+% of them is the distance between the renal arteries and the flow device poses a lot of limitations on the options moving forward. The stiffness and the tortuosity limits what you can get there and what you can do once you get there. And then kind of the characteristics, once again, the metal, whether it's across the orifices or if it's metal on the screen trying to distract you, really causes a lot of challenges intraprocedurally for these patients. And that's it. I hope I set this stage appropriately for Dr. Mawad to talk about open aortic surgery after EVAR.
Thanks so much, Wes.
Yeah, thank you. Thank you, Dr. Woman. I'd like to introduce Dr. Nicholas Mawad, Chief and Medical Director of Vascular and Endovascular Surgery and Vice Chair of the Department of Surgery at McLaren Health System, Bay Region in Bay City, Michigan. Thank you, Dr. Mawad, for talking about open conversion after endovascular aneurysm repair.
Thanks, Dr. Martino, and thank you for the Midwest for the opportunity to present. It's always challenging to follow everyone else. Thanks, Wes, for setting the stage. So I'm going to talk about EVAR conversion to open, and here are my disclosures. And my colleagues previously have just discussed how, really there's been a flurry of EVAR procedures now that's really taken over the management of abdominal aortic aneurysms, even more proximal or visceral aneurysms. As was mentioned earlier, over 85% of aneurysms now are done via endograft. So I'm going to be the big bad guy now and talk about open repair and what happens when sometimes you're unable to, let's say, refix a previous EVAR with further endovascular techniques. As was discussed previously, study after study was shared, the DREAM trial, the EVAR-1 trial, the OVER trial, and so forth. We know that the durability EVAR is controversial and what's challenged. Some papers say that it becomes equal to open repair at 2.4, 2.5 years, others at 8 years. And the New England Journal paper, again, was 8 years, where they felt that both have become equal, and the benefits of early perioperative benefits tend to go away, and then open repair tends to be more durable with less need for reintervention and less need for less cost for reintervention. As is seen here by Rich and colleagues in JVS, again, patients that undergo endovascular repair still have an increased aneurysm-related mortality of 3.6%. There still is a delayed rupture, and there's a not an insignificant major reintervention rate, which are either endovascular or requiring open reconstruction at a later date. So I'd like to share really two main and very contemporary studies, one looking at the National Surgical Quality Improvement Program, the NSQIP program, another looking at the specific vascular quality initiative that I'll share with you all a little bit later. But as you can see in this recent paper by Ibrahim and colleagues, open conversion after failed endovascular repair, looking at 9,000 and change patients that underwent open repair. 385 of those were converted to an open repair, and these are all patients that underwent EVAR from 2009 to 2018 that had a non-urgent conversion after a failed EVAR. During this 10-year period, interestingly, we see that we know that the graphs show that the rate of open repair up front for index aneurysms have been decreasing, and there have been increasing index EVARs for abdominal aortic aneurysms. But as expected, the annual number of cases of conversion to open repair are actually increasing, despite having primary index repairs decreasing. And that's due in reason for failing EVARs. So despite most not having done open repair, now they're being forced to do more complicated open repairs in a conversion fashion for failed EVAR. And you can see that in the graph. So in the study, in this group, was noted to see that postoperative complications were similar between both groups, except for essentially cardiac arrest and mortality in the conversion rate. So 30 mortality was higher in the open conversion group rather than the open repair group that had index repair. Open conversion was also independently associated, again, with mortality, you can see. And there's multiple other factors that are noted with mortality, including, as we would expect for patients with vascular disease, diabetes, COPD, presence of dyspnea, arrest, congestive cardiac failure, and so forth, higher ASA class. Importantly, because the number of patients undergoing EVAR are increasing, it's not surprising that the number of cases requiring open conversion will also be increasing, although the problem is that this should not be practitioners' first episode of dealing with an open aortic aneurysm. Other explanations for this, again, were greater adoption, was shared by my colleagues earlier, for EVAR in younger age groups, patients that have complex anatomy or unsatisfactory anatomy, and the increased use that we see with EVARs for aneurysms that are outside the IFU, which really go upward to 1/3 to 2/3 of EVARs that are seen. Again, numbers of open conversion are noted to have worse outcomes regarding patient selection for the initial AAA repair. Importantly as well, from a disparity perspective, the study showed that the proportion of Asians in the open conversion group was relatively high. And the reason for that was felt to be because they have more challenging aortic iliac anatomy compared to other races, and more technical difficulties in inability to try to deliver the endograft to the site of treatment. So this was in the NISQIP data. Looking at the VQI, which is a little bit more vascular specific, in almost 16,000 EVAR patients, and 1.9% were converted to open, some early and some a little bit later. This by Suko, Scali, and colleagues, as well, looking at this large cohort of patients in JVS here in 2022. And again, this is a first study to really document the incidence and outcomes of open conversion, and looked at Medicare claims via Vascular Implant Surveillance and Interventional Outcomes Network. Again, looking over a 13-year period from 2003 to 2016. And again, as you saw earlier there, 1.9% open conversion rate, some early, some late. But importantly, and we'll dive through this data here shortly, women, patients with large aneurysm over 6 and 6.5 centimeters, those with complex anatomy, were increased risk for open conversion, and those that actually underwent open conversion had an increased mortality. Unfortunately, you can see at the lower part of the screen here, most conversions performed in the early postoperative period are when they generally occur despite people thinking it's a delayed or long-term chronic problem. Conversions associated with significant morbidity and mortality, and it's important again that EVAR after endograft may not be the appropriate thing at the index procedure for patients suffering from abdominal aortic aneurysms. Just delving into the data just a little bit specifically, EVAR conversions were more commonly seen in females, as you can see here with the low p-value. Regarding other comorbidities, they are relatively the same between those that did not have a conversion or those that were converted, again, COPD, diabetes, chronic kidney disease. Again, with sizes being larger, it was more statistically significant that it required a change. Again, to the lower part, which I was a little bit surprised in the data, that surgeon annual EVAR volume and EVARs per year did not seem to have a significant change, which I thought was relatively interesting in the study itself. And this is, again, looking at mortality and length of stay. I'm just going through this a little bit quickly, but overall, all-cause mortality after EVAR was around 25%. The single most important predictor for all-cause mortality was conversion to open repair based on statistical modeling. Patients that had EVAR conversion had a 2.5 increased risk of death compared to those that did not go conversion. And again, the most protective variable against mortality was an elective EVAR. It was as was shared earlier on, the larger the aneurysm itself at the time of index EVAR was associated with a greater 40% increased likelihood of death. And again, there are several comorbidities, as noted there, with congestive cardiac failure, COPD, and chronic kidney disease that were concerning for mortality following EVAR in and of itself. So looking at the Medicare data, independent predictors of conversion were female sex, larger aneurysm size at the index procedure, non-elective repair, and aorta uni repairs. Again, in contrast, adjunctive procedures such as endoanchors and cuff extensions were protective against long-term conversion, which was interesting. And then both early and late open conversions were associated with significant 30-day and 1-year mortality. So the point is, upfront, if you don't have an appropriate case for EVAR or believe they will do better with an open repair, you should consider that, because converting at a later date increases their risk for mortality. I thought this was interesting, despite all of us talking about EVAR and us advocating open repair for good physiologically fit patients. There is tons of money out there in EVAR, and the market out there continues to promote use of endovascular repair, looking at some of the venture capital things that are out online. Again, there's some predictive market research that I found as well that expect aneurysm repair to be increased dramatically, even up to 2028 with a large market cap. But what I say is that repairing an EVAR with an EVAR may not be the right thing. This is a case of one of our explants where you can just see trying to put another EVAR in a previous EVAR and another EVAR in that, trying to solve the problem might not be the right thing, and maybe an open repair up front would be the right thing to do. Because if it's not working, then it probably just should be in the bucket. And for those of you that are on Twitter, we'll see a lot of times where we show these explanted cases. The best way to manage a failed EVAR or endograft or stents that shouldn't be in an appropriate position are probably in the bucket. The screen right again, I'm at College of Wisconsin, all this was actually all in one patient. And so sometimes the appropriate thing would be to do the open repair. So with that, I thank you all very much for your attention.
Thank you, Dr. Mubad. That was really excellent. Our final speaker is Dr. Caputo from the Cleveland Clinic, talking about frozen elephant trunk and hybrid devices. Do things right the first time to facilitate subsequent care. And after that, we will have some discussion. So thank you, Frank.
Hello, everybody. I am, excuse me. Can you guys see my screen okay? Great. Good.
Yes.
Hi, so I want to appreciate everyone giving me the opportunity to talk about an operation I don't do, but it's really been a game changer for us as vascular surgeons. I know we deal with this quite a bit. And so I was charged with talking about frozen elephant trunks and hybrid devices, do things right the first time to facilitate subsequent care. And I just want to say how impressed I am with the Midwestern Vascular and our society with having such a great program. And if you look at some of the attendees, there's some real young people on the audience, some older people, and it's just good to see a bunch of friends getting together on a Thursday night. All right, here's my disclosures. So I was going to start with a case, and we've all had it. Whether you're at a tertiary care center or a primary care center, we have a 60-year-old male who presented with an IMH of the ascending and subsequently was operated on at an outside hospital. His initial operation was a hemiarch with valve resuspension, and 2 years later, he presents with the following. The distal anastomosis, right? And how many times have we seen this where we get consulted by our cardiac colleagues and go, hey, what can we do with this? And you go, what can I do with this, right? I mean, I don't know. So, you know, the initial operation did get that person out of trouble, but now 2 years later, we're dealing with a potentially highly morbid reoperation, potentially trying to do some type of endo case to try to fix this, but this is not an uncommon problem. When you're doing these hemiarches or these little ascending grafts, tend to be sewing to weaker tissues, dissected tissues. So what can we do about this? So what is a frozen elephant trunk? So I would be cautious, you guys typing in frozen elephant trunk on your Google, but you know, if you try to look at the etiology of what the word comes from, there is a lot of folklore about where frozen comes from, whether it was put in during circ arrest or what is because it's a static graft, but essentially it really has become a game changer and allows cardiac surgeons to not just deal with ascending pathology, but also start to treat zone 1, zone 2 pathology as well. And typically it was initially first described in acute type A dissections. And depending on what institution you're at, this is either the standard of care or it is a complete scarlet letter, just to mention frozen elephant trunk. But it really has established conversation between vascular surgeons and cardiac surgeons, because it now allows us to see as the aorta as a diseased entire entity and allows us to really talk about how we're going to fix it and future planning. The frozen elephant trunk and stage repair, it's really about the strategy, right? So it's a versatile technique for the treatment of complex pathologies. It continues to be improved. We have companies are putting out extensions, one-piece frozen elephant trunks where we don't have to necessarily put a conventional TVAR in, hopefully decreasing circulatory arrest time. But we have to remember that a lot of times the frozen elephant trunk, much like a soft elephant trunk, it may not be a definitive repair. We are trying to set ourselves up potentially, and we'll see some cases about this, about how to deal with pathology down the line. A lot of times, though, we do have to deal with that proximal aortic pathology in order to kind of set the stage for definitive aortic repair. And there really is not a ton of data on frozen elephant trunks and subsequent staged aortic procedures. It's become well established. I mean, people are doing it for sure. And it's really what we're trying to figure out is how much of a frozen elephant trunk do we do? Do we do a longer piece to facilitate more remodeling, or do we tend to do a shorter stent graft to hopefully try to prevent some spinal cord ischemia risk? But it's really both of these. Any frozen elephant trunk you do has been associated with a role of secondary intervention. And it seems like in vascular surgery, particularly, the word secondary intervention has become a dirty word. Like, you don't want to do them, right? So I think you have to really distinguish between what a staged surgery is, meaning you're setting yourself for your next part, versus, oops, I got to do something now, and I wasn't planning on doing that. And I think that is something that has to be distinguished. Here at the Cleveland Clinic, we've established, and as the work of Dr. Roselli really has pretty much established the branch single anastomosis frozen elephant trunk repair. And this is pretty much our go-to here. And this is just how things have evolved. And this kind of gives you an idea of the conventional frozen elephant trunk, and also being able to fenestrate that left subclavian artery with a simple stent and a fenestration versus actually doing a branch device or another branch to the left subclavian, minimizing your circuit rest time. So just to give you an idea of how we kind of put these things into perspective. So we have a 56-year-old male who kind of undergoes a type A dissection 5 years ago at an outside hospital. It's not Ohio State, so it's an outside hospital, and now presents with chest pain. And he has this. And what we're seeing is a now disruption of the proximal, where we see an aneurysmal degeneration with, he actually had wide open AI here. And what seems to be degeneration of his entire descendant thoracic down to his iliac. So how do we tackle this? So, the cardiac calls you, says, hey, what do you think? I go, what do I think? You got to fix the proximal and fix the heart prior to fixing the aneurysm. And this is where the conversation should begin. And you got to really start talking things out and really start trying to figure out how you're going to attack this, right? Because if they fix this and they use a 40 stent graft, you're kind of going to get in trouble with that. Versus if you have the conversation, what sizes should we use? What should we do? It kind of starts making in a sense. So I haven't been accused of looking like Bart Simpson. Chris Christie maybe sometimes, but not Bart Simpson. So, but I think, you sit here and you go, what to do now? And our first part of this was actually doing a frozen elephant trunk, whether you want to call it a Be Safer or a frozen elephant trunk, for all intents and purposes, redo root with subsequent placement of the frozen elephant trunk down into the descendant thoracic aorta. And here we see our stent graft. But now, how do we tackle this thoracoabdominal aneurysm? So I think what's evolving, again, this guy is 56 years old, relatively healthy with the exception of his aortic pathology. How do we tackle this? And this is where we are starting to evolve into a hybrid approach to aortic surgery, where now we did a completion open thoracone. We actually sew to the stent graft, and whether you want to call it a hybrid approach to thoracoabdominal aneurysm, we just published a paper with the title ultra hybrid approach. I'm not sure what ultra means, but it's the ultra hybrid approach. So I think is where you got to start thinking about how we can work together with our colleagues in cardiac. And I think this is where technology really does help out a little bit. And I think staging really does help. And I think, when you do stage aortic pathology, you have decreased complications, not just in your visceral metabolic problems, but you have a decreased chance of paralysis, you have decreased overall morbidity. And I think that you're able to let the patient recover and do stage-wide progression of their aortic disease. How do you plan to succeed? Once you start thinking about your frozen elephant trunk, do we have to do anything more? Is that frozen elephant trunk enough to remodel the type A and call it a day? Do we have to think about, do we have to bridge the thoracoabdominal between the frozen elephant trunk and the open repair with TVAR? Should we consider any of the, there was an excellent JVS web Twitter event last night about false lumen obliteration. Can we talk about false lumen obliteration? How are we going to deal with the entry tears? And I think these are all things we have to start thinking about when we are dealing with post frozen elephant trunk implantation and the residual disease. So just to give you an idea, if you do also happen to have a person that does not have a frozen elephant trunk, in case there are devices out there to help us too, which is kind of like the reverse frozen elephant trunk, where we're able to actually do a debranching and actually place commercially available devices to help seal things. So without that, I think complex aortic surgery requires multidisciplinary approach. I think don't be shy of staging complex problems. I mean, we do it all the time, and a lot of centers are doing it. And aortic disease and dissections in particular is chess, not checkers. So I really want to take the opportunity to let me talk about one of the passions of mine, and look forward to any questions.
Thank you, Frank. That was excellent. And the questions, we'd like to see some in the Q&A. Just don't be shy. But I will start off. I mean, we kind of ran the gamut of everything in terms of some complex aortic work and some straightforward aortic work. But I have a question for the panel. Maybe we could just go down the panel and you can talk about how you approach this. But I think more and more people are talking about the size of the aneurysm in terms of the outcome in open versus endo. And I have to say that, when we first went into endo, we didn't really think, we kind of treated 5.5 and a 7 the same. So we consider them the same. But we're seeing now, I think, that the failure rate is different for them. So I think if you saw someone anatomically suitable, with an IFU, but had a 7.5 centimeter aneurysm and would otherwise be fit for surgery, are people treating them with open or endo? Or I don't know, maybe Dr. Kawusi could start and give her.
Sure. Thank you for the question. So I think, as you mentioned, there are good studies out there, the large aneurysm study being one, that if someone does have an aneurysm measuring more than 6.5 centimeters in diameter, they're prone to EVAR failure essentially down the road. And I think that in our practice, if someone, I think everybody's a little different, but I would say if someone falls within the IFU, but has a large aneurysm, but is fit for surgery with long life expectancy, our group here at Henry Ford would probably consider doing an open repair versus an endovascular repair.
And any other panelists weigh in on that, or?
Yeah, I think, and this goes along with Dr. Ambani's questions in the Q&A. I think we're starting to see a little bit better understanding of who fails endovascular repair. And I think we're starting to see the pendulum shift a little bit for those with ultra large aneurysms, are really kind of pushing the age up a little bit as critical care and our understanding of the disease process gets a little bit better. And so, to all things being equal, it kind of comes down a lot to your preoperative risk stratification. And there are certainly some 60-year-olds that I would not sign up for an open aneurysm repair. And there are some 85-year-olds that I would sign up for an open aneurysm repair, but just balancing kind of the size of the aneurysm, the fitness of the patient, and then, never underestimating kind of the power of the retroperitoneum and being able to kind of easily mobilize a safer clamp site, even if I don't necessarily need to put them through that.
The one thing I would add is, getting back to the size of aneurysm, there is no doubt that thrombus in there and the flow lumen is a biological active complex milieu that we've all seen it, right? We do an EVAR and it's growing. We don't know why. And the guy's not feeling great. And you open it up and it's got this heterogeneous junk in there. We've all seen it, right? Some fresh, some old. You don't identify a leak. Maybe there's a type 3, maybe. And the next day, the guy's like, I feel kind of better, actually. He doesn't feel as fatigued or whatever. And I think when you have such a burden, and there's plenty of data to suggest this, right? When you such that thrombotic burden, there's no doubt that there's some inflammation going on there. And I think that's a large part of it for me. If I see a guy who's 65 with an 8-centimeter aneurysm, it's very hard pressed for me to put an EVAR on it, even with the neck, just knowing that he's going to be sitting around with a sac full of thrombus.
Well, I think we've all seen, like, you could have a great neck and great iliac, but that aneurysm never goes away. And I mean, I'm the oldest one on this call, but I mean, I've followed them for many years, and it still makes me worried because it's still sitting there, and there's still potential for movement and for leak and for, fatigue of the stent and so on. But
And there's no doubt. Oh, go ahead. But there's no doubt sac regression is becoming standard. There's a lot of talk about that. I know we've talked about it, Audrey, and I know other people. So I'd like to know what people think about that. What do people think about sac regression? And is that what you're looking for?
Yeah, I think that's tough. I mean, I think that's important. When you see sac regression, I think we all feel pretty good, but I don't know that we always end up seeing that. And the trigger to want to intervene, let's say do another endovascular intervention or convert to open when there's lack of sac regression, I think the threshold for that tends to be a little bit higher for most of us because we know that it's a much more involved procedure. So I think that's something we definitely look for, but I don't think we see it as much as we like.
Maybe we'll go through some more of the questions so we can.
Yeah, maybe we'll just take a moment and sort of, we could probably talk about sac regression and type 2 endoleaks and all that forever. So I want to go back up to one of these earlier questions, Dr. Caputo, for stage procedures, how do you look at timing? How are you managing the risk of interval rupture and the risk of, covering intercostals early and that kind of stuff and spinal cord ischemia, et cetera?
Yeah, well, first of all, I mean, we have that data, thankfully, for the work at Mayo, from the work at the Cleveland Clinic, right? It's about 2% between stage procedures for ruptures at that time. And, early on, people used to keep patients in-house between cases, but they still ruptured, right? So, I just, I tell my patients I don't have a crystal ball, and I wait for them to get back to when they can tolerate it, right? I mean, some patients can get back in 4 weeks. Some patients take a little bit longer, depending on the initial operation. So I just try to do it as swiftly and as efficiently as possible without putting the patient at undue morbid risk. And you're right, the intercostals, I am completely fascinated by the staged intercostal trial going on, embolization trial in Europe. I have not done that personally, but I am fascinated by that.
So I will say, Frank, we have Thoraflex. We've had it for ever since I've been here. So 7 years, we've done about 150 Thoraflex, and I use that to stage. I work at, we do the top, I do the bottom, and I mean it's overwhelming to say to a patient, okay, we're going to sign you up for 3 procedures, but having done a fair number of open, full deal type 2 thoracos, the outcomes and how these patients look. I mean, they don't even go to the unit; they go to a step down unit, and they look tremendous. And I think I haven't had any spinal cord ischemia, and I think it's. So I want to reiterate your point there, but we have like 100 more questions, so we should probably go to those. Dr. Matos wants to know what age everyone gets an open repair and how do you cardiac risk stratify them? Is there any?
We for me, it's probably. I mean, I think age, in addition to the eyeball test, if you will, I think are both important things. For me, it's around 70 years old. I tend to prefer doing open if they're 70 and younger. If they're 70 75, it's a conversation. If they're over 75, I guess it depends on some anatomic factors and so forth. The size of the aneurysm really is not as a big deal for me as the age and obviously the frailty. And we use cardiology. I don't use the SBS calculator. I'd like to hear what my other panelists might use, but we just our cardiologists are the ones that give us a risk stratification.
Yeah, I want to jump on that last point about risk stratification because all of the major trials, POISE, the ones leading to the RCRI, looked at non-cardiac surgery and lumped aortic surgery in with cholecystectomy and appendectomy. And I think there really is kind of an underappreciation of where the clamp is, right? So I supraciliac aortic clamp, I really push now for major stress testing, whatever the cardiologist feels is most appropriate, because I make the point that if I were putting the clamp 6 inches higher with my cardiac surgery colleague and putting them on pump, they'd be getting left heart cath regardless of what the echo shows. And so knowing what you know about the plan for the surgery, I think really drives the conversation or should drive the conversation with the cardiologist and say, look, this is a supraciliac clamp. This is an intramesenteric clamp, and really push for a more expanded preoperative evaluation.
Questions on, so curious, we can go with anybody with the panel wants to jump on this, maybe so we've got some questions about parallel stent grafting versus fenestrated devices. There's an endo anchor question. There's a bunch of options out there, and sort of what's the algorithm or what's the do this in this or don't do this in this situation. Probably there's more right answers than there are, but there's usually a wrong answer for a patient. And sort of how do you sort of go through that in your head?
I think one of the tough things about vascular surgery, and I think Dr. Oman alluded to this, he mentioned it for a hot second, the third option. And I think the one thing about vascular surgery is you can always do something. It's not like a cancer. There's no metastatic vascular surgery, right? So I think one thing is, does the patient should get anything? There's a question on how in a sick patient, should you do anything? Is it okay to say, we're done here? And I think that's number one. And I think that if there is a good endo option where you can actually potentially do something and the guy has a real reasonable lifespan, I think you pursue those options. But I think my algorithm is, for the most part, healthy, not a great neck, not a great thing, open. Not healthy, try something funky. If you can't, if they're really not healthy, go with God. I mean, I think it's okay to say that. I think it's okay to do that. So.
Yeah, I agree. I think what I revert back to is I think the litmus test here is the IFU. So pick parallel stent grafts or PMEGs or FENS or not FENS. If something fits within the IFU of some sort of device that's available out there, that's commercially available, then that's why we revert to. We should use that. And if there's nothing, then at that point you have to get a little bit more creative, like branch and vents and chimneys and snorkels, whatever it may be. But a lot of times, or you might be able to find something on IFU if you look hard enough. And I think that should be the litmus test.
I'd echo that. And I think a lot of it goes with institutional familiarity and comfort, right? We don't do a lot of parallel grafting here, but right down the road, Dave Minion in Kentucky does a tremendous amount of it and has a good results, and he has a good logical way of thinking about it. I think from a broader applicability standpoint, really the question for endo anchors and this idea of ESR versus EVAR, what does that look like in practice? I think is a very active question that's being looked at, and we know that the prelim data supports that there is a very big difference in long-term outcomes from 1A in terms of prevented or prophylactic versus coming back and treat a type 1A endoleak after the endograft is. But who's the right patient? What's the right anatomy and geometry of the aortic neck? I think we throw it in saying, 4 millimeters and you can sneak an endo anchor in, but we all know that 4 millimeters with a reverse conical neck or 4 millimeters with the tortuous neck is going to be fairly different and fairly to behave differently. From my practice, we do, as Frank said, if they're healthy and they can get a reasonable clamp, they get an open operation. It's kind of that gray area of how high am I willing to go, right? To get good parallel wall, to get a good seal. Is that supraceliac? And then I have the philosophical question of, well, it's really just kind of a juxtarenal aneurysm. Do I really want to expose them to that much aortic coverage? Or do I kick the can down the road and say, look, 5.5 applies for infrarenal aneurysms. We're going to watch you until 6 centimeters, because then you're getting a thoracoabdominal functional treatment. And so we're going to put you at that time frame. And I don't think that those questions have really been answered, but that's kind of been my practice.
If I may add, I think that at least in our practice, if someone is older, especially I think a lot of our patients are octogenarians, older in the late 70s, quite frail. I think with a failed EVAR, you could certainly consider doing a fenestrated graft, whether or not PMEG, we do a lot of laser fenestration at Henry Ford. But I think there was a study that just came out from MGH by Dr. Conrad, touching upon the utility of FEVAR in folks and comparing that to open repair. And I think even though the perioperative mortality was lower for the FEVAR group, the 1-year survival was not that different. And I think that they also pose the question of whether or not it's that much more beneficial to put someone under general anesthesia for a longer time, which is usually the case for FEVAR, quite frankly, at times when you compare that to open repair. So
we're going to have to wrap it up soon, but maybe we'll just do one last question. There's several of them, but any ideas on oversizing to get a better seal, or on prophylactic IMA embolization? Any thoughts on those from anybody?
Yeah, I'll jump in. So IMA, if it's over 5.5 or 6 millimeters, we tend to do prophylactic coil embolization for those, just because it's just very frustrating to deal with the type 2 endoleaks from IMA. So we tend to look at that and we attempt an embolization at the index procedure. So we don't generally do it ahead of time to bring them back for the EVAR. So that's for us, at least when it comes to IMAs. And we tend to not oversize more than 10 to 15%, because I personally believe in the hoop stress, and I believe that oversizing too much continues to cause aneurysmal neck degeneration, which is the most frustrating and complicated part to deal with. And as Wes touched on that, dealing with type 1As, and you have to go up and deal with the paravisceral segment and so forth. So we don't oversize 20, 25%, 30%. As a matter of fact, we tend to be as close as possible to 10 to 15, or use a polymer-based endograft or something like that to avoid outward radial force, at least in our practice.
Okay, that's great. Any other comments? Otherwise, I think we'll again thank Terumo and thank all of the speakers. It was really great. And Dr. DiMartino. And thank you all for coming. Thank you, Judith, for organizing.
Thank you.
Thank you all. Thank you.
thank you very much.
Thank you, everyone.
Thanks, everybody.